So, um, looking at the massive stack of notes for today, I have to say I feel like we are crossing a very specific line with this deep dive.
Yeah, I think I know exactly what you mean. We are definitely shifting gears today.
Because we've spent a lot of time in our previous dives talking about the raw architecture of viruses, right? The geometry of the capsid, the DNA, the RNA, all the intricate molecular machinery.
Right, the virology basics.
And it is fascinating, sure, but it's also, I don't know, it's very abstract. It feels a bit like we've been looking at blueprints for a building that hasn't actually been built yet.
That is a really fair assessment. It's the invisible biology. You can't see a lipid envelope without an electron microscope. But today, we are bridging that gap. We are leaving the microscope behind and walking right up to the hospital bed.
Exactly.
We are taking all that blueprint data and asking the critical question, what does it actually look like when that building is on fire? What does it look like when this machinery hits a real, living human being?
And to do that, we are diving into Murray's medical microbiology, specifically Chapter 38, Role of Viruses in Disease.
Yes, and we are going to be sprinkling in some really key mechanical insights from Chapter 50 of Jewett's, Melnick, and Edelberg's medical microbiology to really flesh out the how behind the why.
So the mission for you, the listener, as you join us on this deep dive, is to build a mental framework. Because, well, there is a massive trap here.
Oh, a huge trap. Medical students, and honestly even experienced clinicians sometimes, fall into the trap of just memorizing lists. They try to brute force it. Virus A causes symptom B.
Which is exhausting.
It is exhausting and it's inefficient. But if you actually understand the mechanism, the underlying how, you don't have to memorize a random list. You can just predict the clinical outcome.
You called this the fingerprints of disease when we were going over our pre-show notes?
I did, yeah.
Yeah.
Because every virus leaves a very specific pattern of destruction behind. Our job today is to help you learn how to read those patterns. We are finally moving from pure biology to pathology.
It's one thing to know a virus has a lipid envelope, but it's another thing entirely to understand that because it has that fragile envelope, you generally won't catch that specific virus from drinking a glass of tap water.
Exactly. The structure dictates the clinical reality.
That is a specific connection I really want to get into later because it honestly blew my mind when I read it in the text. But to get us started, I want to throw a metaphor out there that Murray uses, which I think frames this entire topic perfectly. The host pathogen chess match.
It really is the perfect way to visualize this, because disease isn't just a virus attacking some passive victim. It is a highly dynamic, aggressive interaction.
Right, so the virus makes the first move. Entry, spread, attempting to hijack the cellular machinery.
And the host counters immediately. We have physical barriers right off the bat, like skin and mucus. Then we have our innate immunity, things like interferons, which act kind of like a cellular Paul Revere, warning all the neighboring cells of an attack.
And then eventually, if that fails, we bring in the heavy artillery.
The adaptive immunity, the antibodies and the targeted T cells.
So what is the result of this intense chess match?
Well, the result is what we clinically call disease. And here is the real kicker. And this is a central, overarching theme of Murray Chapter 38. Much of the disease, the actual symptoms you feel, isn't just the virus blowing things up. It's collateral damage from the battle itself.
That is such a huge concept to internalize. The fever, the muscle aches, the profound fatigue that's often us fighting back, not the virus inherently winning.
Precisely. So as we go through all these organ systems today, keep that chess match in the back of your head. Ask yourself, are we looking at direct viral damage, or are we looking at the immune system's scorched earth policy?
Let's jump right into section 1 then, the determinants of disease. Basically, the big why. Why does one person just get a mild sniffle and another person ends up intubated in the ICU with the exact same virus?
Murray outlines 5 specific factors of severity, and we really need to unpack them because this is the foundation for everything else we will talk about.
Factor number 1 is host defense.
And this is the primary variable. This dictates the opening moves. Can the patient stop the spread before the virus hits a vital, vulnerable organ?
Right.
If you have a really robust, rapid interferon response, maybe the virus stays confined to your nasal passages. If you don't, maybe it gets deep into your lungs.
Can we pause on interferons for a second? I feel like that word gets thrown around constantly in immunology, but what is it actually doing mechanically in this specific context?
Okay, think of it this way. When a cell gets infected by a virus, it knows it's doomed. It's a goner. But before it dies, it synthesizes and secretes interferon.
Like a distress flare.
Exactly like a distress flare. This chemical floats over and binds to the neighboring, still healthy cells, and it essentially tells them, lock the doors and shut down all the factories. It literally tells the neighbors to stop making protein.
Because if the neighbors stop making protein, the virus can't replicate inside them, even if it gets in.
Right. It creates a firewall of dead or dormant cells around the infection site.
So if my firewall goes up fast, I get a minor cold. If my firewall is slow to deploy,
the virus outruns the warning. It spreads deeper into the tissue. Same exact virus. Wildly different outcome, purely based on the speed of the host's defense mechanisms.
that makes perfect sense. Okay, factor number 2, target tissue.
I like to call this the real estate principle. Is the virus attacking something cheap and replaceable, or is it attacking something totally irreplaceable?
Give me an example of cheap real estate in the body.
The lining of your intestine, the gastrointestinal epithelium. We slough those cells off constantly anyway, so if a virus, like say rotavirus, comes in and kills a huge swath of them, you get severe diarrhea.
Which is messy and awful.
It's extremely unpleasant, yes, but in 3 to 5 days, your body grows entirely new cells. You are completely back to normal. The real estate was cheap.
And the expensive real estate.
Neurons,
Well.
brain and spinal cord cells. Generally speaking, mature neurons do not regenerate. For the most part, no. If the poliovirus or the rabies virus gets in and kills a motor neuron, that specific motor function is gone permanently. That structural damage is irreversible, which is exactly why central nervous system infections have such incredibly high stakes.
High stakes real estate indeed. Okay, factor number 3 is virulence.
This refers to the inherent aggression of the specific viral strain. Not all influenza viruses, for instance, are created equal. Some strains have genetic distinctives, specific mutations in their genome that just make them replicate much faster or hide much better from the immune system.
Factor number 4, and you touched on this earlier, immunopathology.
This is a crucial concept for your medical exams and for clinical reasoning on the wards. You absolutely have to realize that the immune system is a massive double-edged sword.
Because inflammation is designed to kill the virus.
It is, but inflammation also heavily damages surrounding tissue. Let's look at hepatitis B as a prime example. The hepatitis B virus itself isn't actually that directly toxic to the hepatocyte, the liver cell.
Really? It doesn't destroy it.
Not directly, no. It just wants to quietly sit inside the cell and use the machinery to replicate. It's a squatter.
So why do Hep B patients turn bright yellow and go into fulminant liver failure?
Because the immune system, specifically the cytotoxic T cells, are constantly patrolling the liver. They recognize the viral antigens on the surface of the infected cells, and they initiate a deliberate kill order.
They destroy the liver cells to shut down the viral factory.
Exactly. The intense jaundice you see clinically, that is the direct result of your own body aggressively killing its own liver tissue just to clear the virus.
So in that specific case, the attempt at a cure is literally the cause of the disease symptoms.
Yes, the immunopathology is the disease. And finally, we have factor number 5, which is repair.
Meaning, can the body fix the damage once the war is actually over?
Right. If the inflammatory scarring is too severe, like what we see in post-viral pulmonary fibrosis, the organ might just never work the same way again, even long after the virus is completely cleared.
Before we move on to the specific organ systems, I want to bring in a concept from Jowett that I found absolutely fascinating, the iceberg concept.
Oh, yes. This is a vital mental anchor for anyone studying infectious disease.
Because when we study medicine, we spend all our time looking at dramatic textbook pictures of rashes and memorizing charts about high fevers and organ failure.
Right. We are intensely studying the clinical disease. But Jowett reminds us, quite sobering really, that clinical disease is just the very tip of the iceberg.
Just the visible part sticking out of the water.
Exactly. Beneath the surface, the vast, vast majority of viral infections are entirely inapparent or subclinical.
So for every single patient you see walking into a clinic complaining of severe symptoms,
there are likely many, many more people out there who are actively infected, actively replicating the virus, maybe even actively shedding it, but they feel absolutely fine. They have zero clue they are infected.
I mean, that is a little terrifying from a public health or epidemiological standpoint.
It's deeply terrifying. But it is exactly why viruses spread so effectively. Think about it. If everyone who contracted a virus immediately turned bright purple and collapsed on the floor, we'd be able to contain outbreaks incredibly easily.
Because we'd see exactly where it is.
Right. It's the silent spreaders, the massive invisible base of the iceberg that keep the transmission chain going across populations.
One last underlying principle before we hit the actual organ systems. Viral tropism. Called this the real estate principle earlier, but let's get into the actual mechanics of it.
Tropism basically asks the foundational question, why does hepatitis B hit the liver? Why does influenza hit the lungs? Why doesn't the influenza virus attack your big toe?
It's definitely not just random bad luck.
No, it's a very precise molecular lock and key mechanism. The virus has a specific viral attachment protein on its surface. That is the key. And the host cell has a specific receptor on its surface. That is the lock. If the lung epithelial cell has the lock that perfectly fits the influenza key, the virus can enter. If a liver cell doesn't have that lock, the virus literally just bounces off. It can't do anything.
But getting in is really just step one, right?
Yeah.
Jawlitz talks about this distinction between susceptibility and permissiveness.
Correct, and that is a major exam concept. Susceptibility just means, can I get inside the cell? Does the cell have the right receptor?
Lock and key.
Right. Permissiveness, on the other hand, asks, can I actually replicate now that I am inside? Does this specific cell have the exact intracellular machinery I need?
Like enzymes or specific proteins.
Exactly. Does it have the right transcription factors? It's kind of like breaking into a factory. It doesn't help the virus if it breaks in, but doesn't know how to operate the specific assembly line inside. You absolutely need both access, which is susceptibility, and compatibility, which is permissiveness.
Okay, we have our solid framework now. We have the chess match, the iceberg, and the lock and key. Let's take this directly to the human body. Section 2, oral and respiratory tract infections. Murray calls this the single most common site of viral infection.
And logically, it's the main highway. Think about it. We breathe thousands of times a day. We are constantly inhaling microscopic particles and droplets. It is overwhelmingly the easiest portal of entry for any airborne pathogen.
But not all respiratory viruses act the same way once they get in. We really need to distinguish between what we can call the squatters and the travelers.
That is a fantastic way to conceptualize it. You have your local spreaders, the squatters. These are viruses like rhinovirus, which causes the common cold, or influenza.
So they enter the respiratory tract, they infect the respiratory tract, and they stay right there.
Exactly. They do all their dirty work right at the initial portal of entry. The infection and the disease are localized to the same tissue.
And the travelers?
These are your systemic viruses like measles, mumps, or varicella zoster, which causes chickenpox.
But you catch those by breathing them in, right?
You do. They enter through the lungs, but they absolutely do not stay there. They use the respiratory tract merely as a launch pad. They replicate briefly, jump into the lymphatic system, get into the bloodstream, a state we call viremia, and then they spread systemically to cause major disease elsewhere, like a massive rash on the skin.
So, as a general rule, if I have a runny nose and a cough, it's likely a squatter. If I breathe something in and 2 weeks later I'm suddenly covered in full-body spots, it was a traveler.
Broadly speaking, yes. The clinical symptoms perfectly reflect the underlying pattern of spread.
Let's break down these clinical patterns, starting right at the top anatomically. The upper respiratory tract, or URT, we've all had the common cold.
Rhinitis, severe nasal congestion, maybe a bit of a scratchy throat. The key players you need to know here are rhinovirus and coronavirus.
And just to clarify for the listener, we are not talking about the specific pandemic coronavirus here.
Yeah.
Just the broad family in general, right?
Right. The endemic common cold coronaviruses, there are quite a few of them circulating. They infect the nasal epithelium. They cause some intense local inflammation again, the chest match, resulting in sneezing and excess mucus production, and then your body successfully clears them.
Now let's move down just an inch or two. Pharyngitis, the classic sore throat. This is a massive topic for board exams because you have to be able to cleanly differentiate between the various viral causes.
It's a classic differentiator.
So if I give you a clinical vignette and I say patient presents with a severe sore throat plus pink eye, what are you immediately thinking?
That is a rock-solid classic association. Pharyngitis plus conjunctivitis, the pink eye, is essentially pathognomonic for adenovirus.
Pathognomonic meaning it points directly to that one specific cause.
Right. It's often clinically referred to as pharyngoconjunctival fever. It spreads incredibly easily in summer camps, swimming pools, close military quarters. So sore throat plus red eyes equals adenovirus. Lock that in.
Okay, let's change the scenario. What if I look in the back of the patient's throat and I see distinct blisters, vesicular lesions?
If the clear blisters are located specifically in the back of the throat, on the soft palate or the uvula, that condition is called herpangina, and the specific viral culprit is Coxsackie virus.
And what if those same lesions are in the front of the mouth?
Then you are usually dealing with herpes simplex virus, or HSV. That clinical presentation is called gingivostomatitis. You'll see painful lesions on the lips, the gums, and the anterior tongue.
So a quick geographic rule. Back of the throat is Coxsackie A. Front of the mouth is herpes.
That is exactly how you should anchor it in your mind.
What about this scenario? A patient comes in with a genuinely terrible sore throat. Their tonsils are massively enlarged and covered in thick white exudate, and they are profoundly exhausted. It looks exactly like strep throat, but the rapid strep test comes back negative.
That is the textbook presentation of Epstein-Barr virus, or EBV, causing infectious mononucleosis.
The kissing disease.
Right. It mimics strep tonsillitis incredibly well, but the profound, lingering fatigue is your major clinical clue. And don't forget, mono is actually a systemic disease that just happens to prominently start in the throat. It affects the liver and spleen, too.
Moving further down the anatomical pipe, we are leaving the upper respiratory tract and heading down into the lower respiratory tract, the LRT. Let's talk about a sound that absolutely every parent dreads hearing in the middle of the night, the barking seal cough.
That specific, harsh sound is the absolute hallmark of croup, technically known as laryngotracheobronchitis.
That is quite a mouthful of a word.
It is, but it perfectly describes the anatomy involved. The virus causes intense inflammation and swelling, specifically in the subglottic airway, which is the narrow area just below the vocal cords.
And in a small child, that airway is already tiny to begin with.
Exactly. When it swells even a millimeter, it gets dangerously tight, and air rushing through that narrowed space creates that high-pitched inspiratory stridor and that classic barking cough.
And who is the usual viral suspect for croup?
Parent influenza virus. That is the undisputed #1 cause of croup. If you see a question mentioning the steeple sign on a neck x-ray, which is the radiographic narrowing of that airway, you should immediately think parainfluenza.
Okay, let's go even deeper into the lungs, down to the very small airways. Bronchiolitis.
Now we're primarily in the realm of young infants. Bronchiolitis is severe inflammation of the bronchioles, the tiny terminal branching tubes leading directly to the air sacs.
Right.
When these tiny tubes swell up and fill with inflammatory mucus in a small baby, it essentially acts like a one-way valve. It causes severe air trapping and prominent wheezing.
The baby is physically working very hard just to breathe. You see their little ribs retracting.
Very hard. It's terrifying for parents. And the #1 cause of this, typically peaking in the cold winter months, is respiratory syncytial virus, or RSV.
So for a medical exam, if you see an infant under 6 months of age presenting with wheezing and severe respiratory distress in January, the answer is RSV.
Without a doubt. Think RSV first.
Now, the word syncytial in there, that's a really weird word. What does that actually mean in this context?
It actually describes the exact mechanism of pathogenesis. The virus produces a highly specific fusion protein.
Okay.
And this protein causes the infected epithelial cells to literally melt together, fusing their membranes into one giant multinucleated, totally dysfunctional blob.
That blob is the syncytium.
Yes. It's like a microscopic horror movie happening in the airway.
Right.
And eventually, that giant fused cell dies and sloughs off directly into the airway lumen, completely clogging that tiny bronchiole.
Incredible. Finally, let's hit the deep lung tissue itself. The alveoli, pneumonia.
Influenza is obviously a massive player here, especially when you're looking at elderly populations, but there's a very specific nuance that Murray emphasizes here that we must cover.
What's that?
Often, the influenza virus itself doesn't cause the fatal pneumonia. The virus primarily targets and damages the protective lining of the lung, essentially stripping away all the ciliated cells that normally sweep debris out.
It's the chess match again. The virus systematically destroys the host's physical defense mechanisms.
Exactly. And by clearing out those defenses, it creates a perfectly pristine, unprotected breeding ground for bacteria.
So what does that look like clinically?
A patient gets the flu, feels terrible for a few days, maybe starts to finally feel a little bit better, and then suddenly they crash. They get dramatically worse, developing a huge spike in fever and a thick, productive cough.
That is a secondary bacterial pneumonia.
Yes, almost always caused by endogenous flora like Staphylococcus aureus or Streptococcus pneumonia.
That biphasic history you just described, sick, slightly better, then suddenly much worse, that is a classic high-yield board question, isn't it?
It is arguably one of the most tested concepts. You have to recognize that the virus kicked the door open, but the bacteria actually walked in and burned down the house.
All right, let's shift gears entirely and move from the lungs down to the gut. Section 3, gastrointestinal tract infections. Murray explicitly refers to these as the armored viruses. Why armored? What are they protecting themselves against?
Well, think about what the stomach actually is functionally. It is a biological vat of highly concentrated hydrochloric acid.
Right, a pH of like 1 or 2.
And if you survive the stomach, you immediately dump into the small intestine, which floods you with bile. And bile is essentially a harsh biological detergent. It's literally designed to emulsify and break down dietary fats.
So if you are a virus and you have a lipid envelope, which is essentially just a fragile little bubble of fat,
The bile will dissolve you instantly. You absolutely cannot survive the trip through the harsh environment of the stomach and upper GI tract.
so logically, to be a successful GI virus,
You generally need to have a naked capsid. You need to be non-enveloped. The rigid protein shell without the lipid layer is incredibly tough. It's literal armor. It can easily survive the acid bath and the bile detergents.
that is such a helpful, intuitive rule of thumb. If the virus primarily causes diarrhea, it's probably a naked virus.
With very, very few exceptions, yes. That is a safe bet for exams.
Let's talk about the clinical presentation then. Gastroenteritis. Profuse vomiting and diarrhea. What is actually happening at the cellular level?
The primary mechanism here is usually direct viral damage to the intestinal villi. These are the millions of microscopic finger-like projections that vastly increase the surface area of the gut to absorb water and nutrients.
And the virus attacks them.
Yes, the virus infects and destroys those mature cells, physically blunting the villi. So suddenly you have dramatically less surface area, you physically cannot absorb water, and you cannot absorb critical electrolytes.
So they just stay in the gut lumen.
They stay in the gut, osmotic pressure keeps them there, and out they come as massive volumes of watery diarrhea.
Who are the usual suspects here?
In infants and young children, historically, the absolute dominant cause was rotavirus.
But widespread vaccination is really changing that clinical landscape now, right?
Yes. Yes, thankfully. The rotavirus vaccine has been incredibly successful. Now, in adult populations or in major outbreak settings like crowded cruise ships, nursing homes, or schools, the reigning champion is definitely norovirus.
I've heard norovirus described by epidemiologists as the Ferrari of viruses.
It is an incredibly apt description. It is horrifyingly infectious. You only need to ingest something like 10 to maybe 100 viral particles to get violently ill.
Wow.
And to put that in perspective, a single drop of an infected person's vomit can contain billions of viral particles.
That is precisely why it sweeps through closed environments like cruise ships like an absolute wildfire.
Exactly. It aerosolizes slightly when someone gets sick, settles on surfaces, and it's so tough it survives standard cleaning.
And you mentioned earlier there's a specific adenovirus that causes GI issues too.
Yes, adenovirus types 40 and 41 are the specific gut adenoviruses. Remember, adenovirus is kind of the Swiss Army knife of the viral world. It causes pink eye, it causes sore throats, or it causes diarrhea, completely depending on which specific serotype you encounter.
Now, here is a massive twist in the plot that Murray highlights, and I think this trips up a lot of students. The Trojan horse of the gut, enteroviruses.
This is a critical distinction to make. The prefix entero literally translates to intestine.
Right, so enterovirus means intestine virus.
It does. But, and this is a massive but, enteroviruses almost never actually cause significant diarrhea.
Wait, really? An intestine virus that doesn't cause intestinal symptoms?
Correct. Poliovirus, Coxsackie virus, echovirus, these are all enteroviruses. They are naked capsid viruses, so they easily survive the stomach acid perfectly. They comfortably replicate in the lymphoid tissue of the gut. But the gut is merely their point of entry. It is just the initial breach in the castle wall.
They don't waste time burning down the entry hall.
No, they are way more ambitious. They slip right through the gut wall, get into the bloodstream causing viremia, and they ride the blood to their actual preferred target organs, the central nervous system, the cardiac muscle, the skin.
That completely explains why polio is classified as an enterovirus, transmitted via the fecal-oral route, but it famously causes devastating spinal paralysis, not just a mild tummy ache.
Exactly. They strictly use the fecal-oral route for transmission between hosts, but the actual clinical disease happens elsewhere entirely. It is a traveler brilliantly disguised as a squatter.
That is fascinating.
Yeah.
So let's actually follow that viewemia. The virus gets into the blood and spreads. Where does it typically go? Well, very often it goes straight to the skin. This brings us to section 4, exanthems and hemorrhagic fevers.
Right, exanthems, which is the medical term for widespread rashes. In clinical virology, the sudden appearance of a rash usually means the virus has gone fully systemic. It is actively circulating in the blood.
Murray divides these viral rashes into two really big buckets, which is helpful for categorization: maculopapular and vesicular. Let's clarify exactly what these terms mean visually.
Sure. Maculopapular essentially means flat red spots, which are the macules, mixed with slightly raised small red bumps, which are the papules. It's your classic, prototypical, measly-looking rash.
And what viruses are we thinking of here?
Think measles, obviously, roseola, which is caused by HHV6, and parvovirus B19.
And fundamentally, what is actually causing that skin to turn red and bumpy? Is the virus eating the skin cells?
No, this is immunopathology striking again. The rash is not the virus directly destroying the skin. It is actually your own T cells and your antibodies violently attacking the virus localized within the tiny capillary blood vessels of the skin.
So it's a vascular battleground.
Exactly. And here is a wild clinical pearl. If a patient is severely immunocompromised and literally has no functional T cells, they might be deeply infected with the measles virus, but they will actually have no rash.
Because they simply don't have the cellular army required to fight the visible battle on the skin. That's incredible.
Precisely. The rash itself is the visible evidence of the immune response.
Okay, now bucket number 2. Vesicular rashes.
Vesicles are distinct fluid-filled blisters. Think of tiny bubbles on the skin. The classic examples here are chickenpox caused by varicella zoster virus or herpes simplex lesions.
And what exactly is inside that blister fluid?
The virus itself, copious amounts of it. And this is a really key infection control difference. A macular rash, like measles, generally isn't highly infectious if you just touch the skin. But a vesicular rash, like chickenpox or an active herpes sore, that blister fluid is absolutely teeming with live infectious viral particles.
You can directly acquire the infection just by touching the broken rash.
Yes, which is a huge safety tip for young clinicians. Never, ever put an undiagnosed vesicle without wearing gloves.
Consider it noted. Now, you mentioned measles just a minute ago. There is a very specific, highly tested sign inside the mouth that actually appears a few days before the full body rash breaks out, right?
You're thinking of Koplik spots.
Yes, Koplik spots. What do they look like?
They look like tiny, distinct white grains of sand sitting on a bright red base, and they are located specifically inside the cheek on the buccal mucosa. If you look in a child's mouth and see those spots, it is measles. Done. It's pathognomonic.
What about common skin warts? Those aren't really exanthems or rashes, right?
No, technically those are papillomas. They are caused by the human papillomavirus, or HPV. In this case, the virus essentially directly stimulates the basal skin cells to proliferate and grow entirely too much, creating a benign nodule or wart. That is direct viral action altering host cell growth pathways, not an inflammatory immune response.
Let's move to the much scarier side of bloodborne infections, hemorrhagic fevers. We're talking about pathogens like Ebola, dengue, yellow fever. What in the world is happening there mechanically?
This is a scenario where the virus specifically targets and heavily infects the endothelial cells. Those are the delicate cells that form the inner lining of your blood vessels.
So it's directly attacking the plumbing pipes.
Right. And when that cellular lining gets severely damaged, the pipes lose their structural integrity. They start to leak. You get massive vascular leakage.
And clinically, what does a leaking vascular system look like from the outside?
Initially, you might see petechiae, which are tiny, non-blanching pinpoint bleeds just under the skin. As it gets worse, you see ecchymoses, which are large spreading druses.
But the bleeding we see on the skin isn't actually what kills the patient, is it?
No, the superficial bleeding is just a visible warning sign. The real life-threatening danger is internal. If you lose enough plasma volume from the damaged blood vessels directly into the surrounding tissues, your overall circulating blood pressure rapidly drops. You lose perfusion to vital organs, and you inevitably go into profound hypertensive shock.
So a virus like Ebola ultimately kills you by essentially making your entire vascular system so leaky that your heart physically cannot maintain enough blood pressure to keep you alive.
That structural failure, combined with a massive uncontrolled cytokine storm where the immune system completely goes haywire trying to blindly stop the widespread virus, yes, that is the fatal mechanism.
It's just devastating. Okay, let's look at some very targeted viral strikes now. Section 5, infections of specific organs. We briefly mentioned the eye earlier with adenovirus causing pink eye.
Yes, viral conjunctivitis. But we really should also highlight keratoconjunctivitis. This is a much more serious condition where the infection actually involves the cornea itself, the vital clear window at the very front of the eye. Herpes simplex, HSV, and varicella, V. levi, can both do this.
And that is significantly more dangerous than simple pink eye.
Extremely dangerous. It can cause permanent corneal scarring. In fact, HSV infection of the eye is one of the leading infectious causes of blindness in developed nations. It classically creates this very distinct branching dendritic ulcer right on the surface of the cornea.
Let's move to a major metabolic organ, the liver. Viral hepatitis.
So we have the alphabet soup here, hepatitis A, B, C, D, and E. Yellow fever obviously hits the liver too. And systemic viruses like EBV and CMV can also cause some significant hepatic involvement.
And here again, Murray really heavily emphasizes the underlying mechanism of the damage.
Because it is the absolute textbook example of immunopathology. With hepatitis B, for instance, the virus robustly replicates in the hepatocytes. But as we discussed, the virus itself typically doesn't blow the cells up. The immune system, driven by cytotoxic T cells, comes along, detects the viral antigens, and intentionally destroys the infected liver cells to halt replication.
So the jaundice, the characteristic yellowing of the skin and the whites of the eyes, which results directly from the liver failing to process bilirubin,
is paradoxically a direct sign that your immune system is actively fighting the infection. In fact, people with severely weakened immune systems who contract hepatitis B might actually become lifelong chronic carriers precisely because they don't mount a strong enough immune attack to clear it.
But the trade-off is they also don't suffer as much acute, severe liver tissue damage initially.
It's a very delicate, complex immunological balance.
What about viral infections of the heart?
We are primarily looking at viral myocarditis, which is deep infection of the heart muscle itself, or pericarditis, which is inflammation of the fibrous sac lining the heart. And the classic highly tested suspect here is Coxsackie virus B.
Coxsackie B. I remember reading a very vivid, almost medieval description for this specific symptom complex. Devil's grip.
Yes, clinically it's known as pleurodynia, or Bornholm disease. It causes this incredibly sudden, sharp, agonizingly spasmodic chest pain. Patients often describe it as feeling like an iron fist or the devil's grip aggressively squeezing their rib cage.
I imagine that violently mimics a myocardial infarction, a heart attack when they present to the ER.
It absolutely does mimic a heart attack, which causes massive anxiety, but it's actually just viral inflammation of the intercostal muscles between the ribs and the pleural lining around the heart.
Let's move on to section 6, the central nervous system, the brain, and the spinal cord. This is the highest of high-stakes real estate.
Because, as we established, the central nervous system is an irreplaceable tissue. Neurons really don't regenerate well at all, so any CNS infection is, by definition, an absolute medical emergency.
How do these viruses even get in there? The brain is supposed to be incredibly tightly protected by the blood-brain barrier.
It is. It's a fortress. But viruses have evolved brilliant ways to breach it. The most common route is hematogenous, meaning via the bloodstream. If the initial viremia is massive enough and sustained enough, the sheer volume of virus can eventually compromise and breach the endothelial barrier. This is exactly how most arboviruses, like West Nile or St. Louis encephalitis or the mumps virus, get inside.
And the other route.
The neuronal route. And frankly, this is the stuff of actual nightmares. The virus bypasses the blood entirely. It infects a peripheral nerve ending deep in the tissue, say, from an animal bite on the leg, and it physically travels backwards up the long axon of the nerve.
Literally climbing the nerve like a cable car straight into the spinal cord.
Yes, retrograde axonal transport right into the CNS. Rabies is the ultimate classic example of this. But herpes simplex can actually do this too, routinely traveling from a cold sore on the lip straight back to hide in the trigeminal ganglion in the skull.
We really need to distinguish between 3 specific clinical words that sound very similar but mean entirely different things: meningitis, encephalitis, and myelitis. This is crucial for both exams and for functioning in an actual emergency room.
Absolutely essential. Let's start with meningitis. This is strict inflammation of the meninges, which are the protective fibrous coverings surrounding the brain and spinal cord. The patient will present with a severe headache, a very stiff neck, which we call neutral rigidity, and maybe intense photophobia, where bright light hurts their eyes.
But this is the crucial discriminator.
Their actual core brain function remains completely normal. They are perfectly awake, they are alert, they know exactly who they are and what year it is. The tissue of the brain itself is not infected.
Yeah, and the primary viral cause of this.
Viral meningitis is very commonly called aseptic meningitis because standard bacterial cultures will come back completely negative. And the absolute number one cause is enteroviruses, specifically Coxsackie and echovirus.
Ah, the Trojan horses strike again?
Exactly. Remember, they enter through the gut, cause zero GI symptoms, but aggressively attack the CNS meninges. HSV2, the genital herpes virus, is another notable cause of aseptic meningitis.
Okay, now let's contrast that with encephalitis.
This is a massive escalation. Encephalitis is direct, aggressive inflammation of the brain parenchyma itself. The actual functional brain tissue is infected. The patient still has a fever and a terrible headache, but they fundamentally have profoundly altered mental status.
Meaning they are behaving abnormally.
Yes, they are deeply confused. They might be hallucinating. They're having unprovoked seizures, or they might be slipping into a coma. Their entire personality might change dramatically in hours.
So focal confusion or seizures instantly means encephalitis, not just meningitis.
Correct. That is your giant red flag. And the single most common sporadic cause of fatal encephalitis, meaning not linked to a seasonal mosquito outbreak, is herpes simplex virus type 1, HSV1.
And HSV1 has a very specific, strange geographical target inside the brain, doesn't it?
It has a bizarre, intense predilection for the temporal lobes. If you look at an MRI of these patients, you will see highly specific unilateral or bilateral necrosis, actual tissue death concentrated in the temporal lobes.
And since the temporal lobes control memory and emotion.
You see totally bizarre behavioral changes, profound amnesia, and complex partial seizures. It destroys the exact hardware we use to process our reality.
And finally, the third term, myelitis.
Myelitis is targeted inflammation of the spinal cord itself. Specifically, viruses that cause myelitis love to target the anterior horn motor neurons, and when you destroy motor neurons, the direct result is flaccid paralysis.
The classic hallmark of polio.
Poliovirus is the historical prototype, but today, West Nile virus can also frequently cause a very similar acute flaccid paralysis syndrome.
So quick summary for the listener. Stiff neck but mentally clear equals meningitis. Severe confusion and seizures equals encephalitis. Sudden muscle paralysis equals myelitis.
That is the perfect high-yield clinical framework.
Let's touch quickly on Section 7, hematologic and sexually transmitted diseases. We've talked extensively about viremia, viruses traveling in the blood, but how exactly are they traveling? Are they just freely floating around like debris?
Sometimes they do float completely free in the blood plasma, but very often they essentially hitch a ride inside a cellular vehicle, and the macrophage is the ultimate Trojan horse here.
Which is incredibly ironic because the macrophage is the primary immune cell specifically designed to hunt down and eat viruses.
Exactly. The macrophage engulfs the virus to destroy it, but viruses like HIV or dengue have evolved mechanisms to survive inside the macrophage. So the macrophage unwittingly migrates to distant lymph nodes or other deep organs, securely carrying the live virus perfectly protected deep inside the body.
And regarding sexually transmitted diseases, HIV, hepatitis B, hepatitis C, herpes, HPV, what is the overarching evolutionary strategy for these pathogens?
Persistence. Above all else, persistence. These viruses universally establish either chronic, low-level infections or completely latent hidden infections. They rely heavily on prolonged, entirely asymptomatic shedding.
Because if they caused immediate severe symptoms.
Think about the evolutionary pressure. If every single time you contracted an STD, you immediately developed massive, incredibly painful, debilitating lesions, transmission would hit a wall. You wouldn't have sex. The virus would burn itself out.
So by hiding, it ensures its own survival. The iceberg concept reappears.
The massive hidden iceberg of asymptomatic shedding is exactly what allows the virus to successfully jump to a new host time and time again.
Moving on to our final major section, Section 8. Chronic, oncogenic, and vulnerable hosts. We just touched on latency, but we really need to talk about cancer, oncogenic viruses.
Yes. Some viruses have the terrifying ability to actually induce host cell cancer. And this generally happens because the virus fundamentally messes with the host cell's internal growth regulation machinery. The virus just wants to push the cell into the replication cycle to make more viral copies, but in doing so, it inadvertently triggers uncontrolled runaway host cell division.
Let's break down exactly how that works mechanically.
Okay, think about the safety brakes on your car. Your cells have specific regulatory proteins, primarily P53 and the retinoblastoma protein, or RB. These are the crucial safety brakes that strictly stop cells from dividing too rapidly or dividing when they have damaged DNA.
So they prevent tumors from forming.
Right. Now, Certain high-risk viruses, specifically certain strains of human papillomavirus like HPV-16 and HPV-18, produce specialized viral proteins called E6 and E7.
And what do E6 and E7 do?
They physically bind directly to P53 and RB and completely degrade them. They literally cut the break lines of the host cell.
And without any breaks, the cell just crashes.
The cell divides completely uncontrollably. It ignores all stop signals, and that unchecked mass of dividing cells is what we call a tumor. Clinically, this leads directly to cervical cancer, anal cancer, and increasingly, oropharyngeal cancers.
What about EBV, Epstein-Barr virus? Does it cut the brakes too?
EBV uses a slightly different mechanism, but it powerfully drives the continuous proliferation of B cells. This is strongly associated with the development of Burkitt lymphoma, especially in regions like Africa, and nasopharyngeal carcinoma, particularly in Asian populations.
And hepatitis B and C.
They are massive global drivers of hepatocellular carcinoma, primary liver cancer. But this is actually mostly an indirect effect. It's often due to the decades-long, grueling cycle of chronic inflammatory immune damage, followed by rapid cellular repair leading to cirrhosis. Constant rapid repair eventually leads to major genetic copying errors, and cancer emerges from the chaos.
And finally, HHV8.
Human herpes virus 8 is the direct causative agent of Kaposi sarcoma, which is a vascular tumor frequently seen in advanced AIDS patients.
Speaking of AIDS, let's look at vulnerable hosts. The severely immunocompromised, and on the other end of the spectrum, the unborn.
With immunocompromised patients, particularly those who have lost their cellular T-cell immunity like an advanced HIV or severe transplant immunosuppression, enveloped viruses just go absolutely wild.
Because the main army defending against them is simply gone.
Exactly. Take measles, for instance. In a healthy kid, it causes a miserable rash, but is usually self-limiting. In a patient with no T-cells, measles can disseminate into the lungs and cause a catastrophic, highly fatal condition called giant cell pneumonia. The body simply cannot contain the viral spread at all.
And for the fetus, the congenital infections. The maternal immune system is working, but the baby is vulnerable.
The placenta is generally an excellent barrier, but some specific viruses have evolved the ability to cross it. Medical students usually memorize these using the classic Torish H mnemonic.
So what are the heavy hitters from that group?
Rubella is the absolute classic viral teratogen.
Teratogen meaning it directly causes severe physical birth defects.
Yes. If a mother contracts primary rubella, specifically during the first trimester, when the organs are rapidly forming, the baby can be born with congenital rubella syndrome. The classic triad is severe bilateral cataracts causing blindness, profound sensor neural deafness, and major congenital heart defects like a patent ductus arteriosus.
That is tragic. What about CMV, cytomegalovirus?
CMV is actually the single most common viral cause of congenital defects in the United States today. Most maternal infections are completely asymptomatic, but it can cross the placenta and cause devastating fetal hearing loss, severe microcephaly, and profound intellectual disability.
And the last one I want to highlight is parvovirus B19.
Right. In young school children, parvovirus B19 just causes erythema infectiosum, commonly known as fifth disease. It causes that very classic bright red slapped cheek rash. It's usually super mild.
But if a pregnant woman who has never had it gets infected,
then it becomes incredibly dangerous. The virus specifically targets and aggressively infects the rapidly dividing red blood cell precursors in the fetal bone marrow and liver.
It effectively stops the fetus from manufacturing new red blood cells.
Exactly. It completely halts erythropoiesis. This causes profound, rapid fetal anemia. The fetal heart has to pump exponentially harder to compensate for the lack of oxygen-carrying cells, leading to massive high-output heart failure. Fluid backs up everywhere, a fatal condition called hydrops fetalis.
It is amazing and honestly terrifying how a virus that just causes slightly red cheeks in a 5-year-old can be absolutely lethal to a developing fetus.
It perfectly illustrates the concept of target tissue vulnerability. The red blood cell precursors are the only cells replicating fast enough for the virus to utilize.
Wow. We have really covered a massive amount of ground today. From the intricate opening moves of the viral chess match to the specific targeted strikes on the heart, the brain, and the liver.
But I hope the listener sees that it all constantly comes back to that very initial mission we stated, decoding the predictable patterns.
Right. Is the clinical presentation purely respiratory? Is it entirely gastrointestinal? Or is it systemic, presenting with a widespread rash?
Exactly. Is the infection acute and self-limiting like influenza, or is it a persistent chronic grind like hepatitis C?
And ultimately, is the severe tissue damage primarily from the direct action of the virus, like polio aggressively killing motor neurons? Or is the damage actually collateral fallout from the immune system, like hepatitis B, destroying your own liver cells?
And always, always remember the hidden iceberg.
Yes, the iceberg. For every dramatic, terrifying case of focal encephalitis or bleeding hemorrhagic fever you read about in the textbook, there are hundreds, sometimes thousands, of entirely silent subclinical infections swimming out there, keeping the virus alive and circulating in the human population.
It really reframes how you look at a crowded room, doesn't it?
It definitely does. Now, before we sign off, we absolutely have to test your recall. It is time for the rapid-fire quiz. I'm going to give you a very brief clinical snapshot. I want you, the listener, to try and answer out loud before our expert steps in with the solution.
I am ready when you are.
Question 1. It is late January. You have a 4-month-old infant presenting in the ER. They have diffuse wheezing, rapid breathing, visible signs of respiratory distress with marked air trapping. What is the most likely viral agent?
That is respiratory syncytial virus, or RSV. It is the absolutely classic cause of acute bronchiolitis in young infants during the winter months.
Question 2. A young child presents to the clinic with distinct vesicular blisters. However, they are located in a very specific anatomical pattern. You find them exclusively on the palms of the hands, the soles of the feet, and ulcerating inside the anterior mouth. Which virus?
That describes textbook hand, foot, and mouth disease, which is classically caused by Coxsackie virus A.
Question 3. A young adult patient presents to the emergency room with a remarkably stiff neck and a severe pounding headache. A spinal tap is performed, and the CSF analysis shows predominantly lymphocytes, which is the classic viral pattern. The patient is completely awake, alert, and oriented. The causative agent is identified as an enterovirus, yet the patient reports absolutely zero recent gastrointestinal symptoms like diarrhea. Which specific group of viruses is most likely responsible?
This is a classic presentation of aseptic meningitis, typically caused by an echovirus or a Coxsackie virus. You have to firmly remember that enteroviruses reliably infect the gut tissue first, but they aggressively travel to cause their primary disease in the central nervous system meninges.
Question 4. A patient is brought in by ambulance, actively having seizures. They are deeply confused and acting highly erratically. An urgent MRI of the brain reveals pronounced focal tissue necrosis, specifically localized to the temporal lobe. Which virus is the most common sporadic cause of this devastating condition?
Focal temporal lobe necrosis, coupled with clinical encephalitis, is basically a neon sign pointing directly to herpes simplex virus type 1 or HSV1.
Question 5. A patient returns from a trip to the deep tropics, complaining of severe, agonizing bone pain, often described clinically as breakbone fever. Several years later, they travel to the same region, get infected again, and rapidly develop a life-threatening shock syndrome with widespread bleeding. Which virus is responsible?
That is the classic clinical course of dengue virus. The second infection is notoriously and paradoxically often much worse due to the phenomenon of antibody-dependent enhancement, which perfectly exploits the macrophage Trojan horse effect we discussed earlier.
Excellent. So how did you do on those? If you missed any of those associations, I highly recommend you go back and re-listen to that specific organ section.
And definitely read the actual text of Murray chapter 38. Specifically, aggressively utilize the summary tables in that chapter. They are absolute gold for tightly linking the specific virus directly to its corresponding clinical syndrome for exam preparation.
I want to leave you with one final, slightly provocative thought to chew on before we go. We spent a lot of time today talking about viral tropism. How these viruses have evolved over millions of years to target perfectly specific human receptors. But think about this. With the massive global rollout of highly targeted antiviral drugs and specific monoclonal antibodies that intentionally block these exact receptors, are we unwittingly applying an unprecedented evolutionary pressure? Are we actively forcing these viruses to rapidly mutate and completely alter their fundamental tropism, potentially opening up entirely new, previously invulnerable organ systems to novel viral attacks in the next few decades? It's something to think about as you study the static textbooks.
That is a very unsettling but highly relevant thought experiment for the future of infectious disease.
That's it for this deep dive. Keep looking beneath the surface of the iceberg. Thanks for listening.
Stay curious, everyone.